this video, we'll take an in-depth look at the records needed to begin a chrome-guided smile case. Although the records by today's standards are very conventional, they are very specific and are necessary for each individual type of case that presents so that we can launch Chrome correctly from the beginning. So in this video we will cover dentate, edentulous single arch, edentulous double arch, and then cases where it's quite common where patients have existing partial dentures, and we can use those partial dentures to establish the bite registration in vertical. Dentate records are very straightforward. In every case, we will need upper and lower cast articulated. It is important to, as you see here, capture the vestibule of the chrome arch of interest. So if it's a maxillary cast, it's important to maxillary arch, it's important to capture the vestibule, the labial and the lingual vestibules, as well as the palate. We need to have the vestibule because the pin guide, the first guide, will often engage the floor of the vestibule and where bone reduction begins. We'll need a CBCT scan of the patient with the teeth separated, either by cotton rolls or a bite stick, or if the patient is biting on the bite fork that's included on the cone beam CT scanner. And of course, it's always multi-file, not a viewer and not a single file, must be multi-file. And then the photos. And we'll discuss the photos in the next few slides. Part of the record collection system is photographs. For all cases that are maxillary or maxillary and mandibular, we require a full face, full smile picture. On these cases, when it's dentate, we will perform a smile simulation, which will show a beautiful before and after smile. We use these smiles so that the doctor and the laboratory can be on the exact same page of tooth position, of tooth exposure, of gingival exposure, and it's just it just gets us off on the same page so that we're communicating right from the beginning. These smiles can be shared with the patient, and often these cases begin even before the records are collected. A smile simulation is completed to show the patient the proposed smile, and that is what we build our case around. In fact, the teeth in these smiles are based on STL files, which are close to a 1-to-1. So in other words, the smile simulation that we provide will share the exact tooth mold and shape of the surgical prosthetic, and then eventually the temporary and the final prosthetic, which is a unique service. The photographs that we require are full face, full smile, which is a camera with the lens set right, pointing directly to the nose. The trouble is often the photographs are taken with the patient lying down in the chair, and so the camera is looking up towards the patient, or often the patient is seated in the chair and then the camera is looking down. It's important that the camera be directed directly to the nose and that the patient is standing up with the eyes in the middle of the orbits and the patient exhibiting a full smile, even an exaggerated smile, because we'll use the upper lip to help us determine bone reduction levels and the junction of the prosthetic and the tissue. With this image, we'll make a smile simulation. Also, the pictures on the right, retracted left, right, and center. Please put the patient in a retractor, in retraction, have the patient in occlusion, and then capture these photographs. We use these photographs when we are determining if the casts are articulated correctly. So we'll make a visual comparison of the articulated models with the photographs on the screen. This helps us tremendously, especially with compromised cases where the bites are very challenging. For a dentate case, just to review, full face, full smile, center, left, and right photographs, retracted and occlusion, a cone beam CT scan. With the teeth separated, you can see the gap between the maxillary mandibular teeth, and then casts. Full cast with as much of the vestibule as possible. Let's go through a few challenging dentate cases and the records that we request in these situations. So, many of these cases, most of these cases involve pathology, involve perio issues, involve patients who have been missing teeth for years, and many patients who do not exhibit a well-established bite. Many cases simply have 4, 5, maybe 6 teeth in the anterior with no vertical stops. In these cases, we request that a bite block be used and a setup, and often that be processed into a scan appliance, and then a dual scan be captured, which we'll talk about a dual scan in the upcoming slides. But as we see here in the red, we do not trust these bites. We've been through many surgeries where these types of cases were presented, and we move forward, and then the bite during surgery is a little bit off, and that's always a tough chrome morning when there's adjustment on the prosthetic. So we really like to establish an ideal centric either CR or CO bite registration that is repeatable and measurable. So on that particular case, bite block, perform a setup, process it in acrylic, add markers to it to make a scan appliance, and then perform a dual scan, which is scanning the appliance in the mouth and then scanning the appliance by itself. We'll get in a little more detail in the upcoming slides. One of the measurements that when we are evaluating casts is the Shimbashi measurement. This measurement dates back a couple of decades. It's very dependable. The Shimbashi, in essence, is a measurement from the gingival zenith of number 8 to the gingival zenith of number 25 in this case, but it can be either central against a lower central. And the average person, the average healthy person without pathology will have a measurement of 17 to 18. And of course, this is on models, but this can also be completed in the mouth, and this will give an indication of whether the patient needs to be opened. There are discussions around this measurement of whether there's supereruption or actual collapse of bite, etc. But this is a very good averages number to use. We see many cases where the bite is very much collapsed. Of course, in the image here, you'll see supereruption as well, but the bite has indeed collapsed and needs to be opened. And then from that point, opened and then confirmed with bite registrations, or what we call a JC Tryon, which we'll also explain. But to evaluate these cases, for this case in particular, there are no centrals, so it's tough to take a Shimbashi measurement. We're going to show you another measurement in a minute called an intervestibular measurement that could help with this case. But just to evaluate these cases, we would need mounted casts, photographs of full face, full smile, and lips at rest, a CT with teeth apart, and then a bite, either centric or in centric occlusion, or CR, or neuromuscular. And at that point, we'll have mounted casts, and we can discuss the bite opening. The CT scan can help us determine bone reduction needs during the workup, but it's not always necessary to determine the vertical. Another case where there's a collapsed bite. In this case, we have good centric stops, comfortable with the bite position. However, just taking a Shimbashi measurement, we'll notice that it's only 13 millimeters, meaning the patient needs to be opened up for maybe 5 millimeters. And that is for, prosthetic space. One option is to just reduce the bone in order to achieve the space, but that's not always feasible. Often opening the bite is needed. And on cases like this, send in the usual records: mounted casts, photographs of full face, full smile, left, right, and center pictures, a centric bite, unless there's another bite the doctor prefers to take and send, a CT scan with the teeth apart, and then at this point, this type of case, we will make what's called the JC Tryon, which we're going to show on this slide here. So the doctor captured this bite, and there was a little bit of rock to it, and it was not totally stable. The Shimbashi measurement was close to an average, so it was on an average 17 millimeters. But just to confirm this bite, 100% stable bite, we made this JC Tryon. Not the most aesthetic JC Tryon. This one's a little particular because of the amount of space we had for teeth. But this is a hard printed bite, essentially, that the doctor will confirm. We'll try it in, equilibrate it until the bite is 100% captured, and even perhaps capture a bite registration between it and the opposing, and then send back the physical models. So this is entering, back into the analog world. So send the upper and lower casts back, send the JC Tryon back. We will re-articulate and then move forward with the case. So this is a JC Tryon. The JC Tryon is designed in software. We articulate the casts. Perhaps we open the bite. At the laboratory, if the case is sent in with a good stable bite, good centric stops, but the case needs to be opened 1, 2, 3, perhaps 4 millimeters. I really like to not open a patient's bite on the articulator more than 3 millimeters, but we will scan the case in an open position. So this case, I believe we're opening it several millimeters, but this case was articulated in the open bite. We use software to essentially make flippers, and then we print them in resin and send them to the doctor for Tryon, for equilibration. And in this case, it was going to be a dual scan technique. So you can see the markers here. These are buried radiopaque markers from a company called Suremark.com. And so the doctor will seat these, adjust them till they fit, equilibrate, and then do a dual scan technique. This is the same case. So this patient exhibited a very close bite, only 11 millimeters of space. And the case was opened. In this case, it was opened on the articulator 6 millimeters. It's far more than we would ever want to do without doing some kind of Tryon. So it was opened. Scan appliances were made as JC Tryons and sent to the doctor for confirmation. It's a very good way to make a stable bite registration. As mentioned before, there is another method for verifying a patient's vertical. Now, in this case, the patient has no centric stops. This would be a case where there would be bite blocks, a setup, confirm and set the ideal bite, and then turn that into a scan appliance, do a dual scan. But just to start off on the right direction, you can take an intervestibular measurement, which, just like the Shimbashi measurement, it's going to be close to 35 millimeters from vestibule to vestibule. This will give us an averages of whether the patient needs to be opened or not. This is another type of dentate case, class 3, very common. These cases really should go the way of orthodontic surgery. Patients often don't opt for that, and instead go for chrome or some other type of restorative procedure. Now, this is severe class 3, and mostly these kinds of cases cannot be restored with a fixed prosthetic. Has to be restored with some type of overdenture with a flange that provides lip support. These cases just in the long run do not work out very well. There's just too much bulking material in the facial to hold the lip, or the prognathic part of these cases just make it not ideal. These teeth are flared out in the final restoration. They could be pushed out, but usually the class 3 cannot be fixed, even though that sometimes that's the desire of the patient. It just cannot be completed with fixed. In these cases, we put it in bold here, we really like to have photographs in profile of patient smiling or lips at rest, so that we can have a conversation about the amount of lip support needed to achieve success. Other cases often seem straightforward. The patient exhibits a repeatable bite. Patient has many teeth that are interdigitating. However, upon immediate review of the laboratory, Shimbaja measurement of only 13, meaning we will not have enough room for materials with just extractions and some bone reduction. Perhaps a more significant bone reduction on the mandible, perhaps will make space, but that's not always the answer. Bone reduction is not always the answer. Opening a bite is often a much simpler approach. Mobile teeth. So again, dentate over dentate, but mobile teeth can pose a real problem for the pin guide. That's the initial guide going in the mouth. Often, we have notes that we send along with the case that indicate that certain teeth need to be extracted prior to the pin guide going in because they're mobile. Often these cases, it's difficult to even take an impression because the impression will remove, or extract these teeth. And so often these cases are, now this was an analog, this is a printed copy of it, but this was an analog impression taken with probably an alginate. But perhaps a digital impression would have helped capture the teeth in the right place. But what we would like to know is a list of which teeth are mobile, or even better in a case like this where probably many of the teeth are mobile, we'd like a list of stable teeth so that perhaps several of the teeth can be extracted prior to the pin guide being placed, so that the pin guide is on stable dentition and can be placed in the mouth in a repeated position in the anterior, or in the maxilla, sorry. We definitely want an image, definitely want to capture the palate so that the pin guide can rest on the palate. So those were all dentate cases, and there's many more types of situations that can present. We always recommend sending in the casts with a request, or simply take some photographs and send them to us, and we can have a discussion about what records are needed for a particular case. And in those situations where we just have photos, things can be expedited.